So let's discuss about the prognostic and predictive factors in breast cancer. This is a very frequently asked question, and it is very important for the clinical practice. So we can divide the prognostic and predictive factors in breast cancer into two types. One is major prognostic factors, mainly determining tumor extent, and another one is minor or biologic factors, mainly histological and molecular. So what do you mean by this prognostic and predictive factors in breast cancer? These are several parameters which will determine how whether the patient is going to be cured or not, or these factors will increase the survival rate, the number of years the patient is going to survive. The survival rate, that is, these factors are important for that survival rate. So first is first is major. First, let us discuss about the major prognostic factors. First is whether it is invasive or in situ. So in situ carcinomas have an excellent prognostic with survival rates more than 95%. Invasive carcinomas have a high risk of systemic spread, that is the metastasis. So if the rate of if there is a high risk of systemic spread, there is a metastasis occurring. So obviously the prognosis will be much worse than in the case where there is no metastasis. The second one is about metastasis, distant metastasis. So this is the most important prognostic factor overall. This is an MCQ. Once distant metastasis occurs, a cure is highly unlikely, though long-term remissions are possible. So what do you mean by this distant metastasis? These distant metastases occur in several organs. There are examples like bones, lungs, liver, and brain. These organs are affected. Next is lymph node metastasis, the most important prognostic factor in the absence of distant metastasis. If there is no involvement of those organs I just told you about, then this is the most important prognostic factor. But if there is any distant metastasis, then that distant metastasis is the most important prognostic factor overall. So this is also an MCQ. Survival inversely correlates with the number of involved nodes. Sentinel lymph node biopsy is the standard for assessment. Sentinel lymph node means the lymphatic vessels in most breast carcinomas drain first to one or two lymph nodes in the axilla, which are known as sentinel lymph nodes. These lymph nodes are usually examined for metastasis. Fourth one is tumor size, an independent prognostic factor. This risk of axillary lymph node metastasis increases with tumor size. That means the prognostic factors affect prognosis of breast carcinoma is inversely proportional to the tumor size. The larger the size, the poorer the prognosis. Tumors less than 1 cm without node involvement have an excellent 10-year survival rate. Tumors less than 1 cm, there is a smaller tumor and no node involvement. Locally advanced disease. Tumors invading the overlying skin, causing ulceration or QD or H, or the underlying skeletal muscle like chest wall, have poor prognosis. Inflammatory carcinoma, presence as enlarged, swollen and erythematous breast. This has a poorer prognosis. Pathologically defined by extensive tumor emboli in dermal lymphatics, causing the swollen appearance. Carries a very poor prognosis. Now the minor prognostic and predictive factors or biological factors. Histologic subtype. Special types, tubular, mucinous, medullary, lobular, papillary generally have a better prognosis. This is an MCQ. Invasive carcinoma of no special type, invasive ductal carcinoma has relatively poorer prognosis. Histologic grade, Nottingham histologic score. This histologic grade evaluates three features: tubule formation, nuclear pleomorphism, and mitotic rate, and it grades the tumor: grade 1, grade 2, and grade 3. Grade 3 has lower survival because of poor differentiation. Estrogen and progesterone receptors. Crucial predictive factor: cancers expressing ER and PR respond well to anti-estrogen therapies. Example: tamoxifen, aromatase inhibitors. PR positive tumors generally have a slightly better baseline prognosis than ER and PR negative tumors, like triple negative tumor, basal-like tumor. This is also an MCQ. HER2 and overexpression. HER2 is a transmembrane receptor tyrosine kinase. Historically associated with aggressive disease and poor prognosis because there was no medicine. But now we have a monoclonal antibody which targets this receptor. Now a major predictive factor: patients respond remarkably well to targeted therapy, trastuzumab or Herceptin. This is repeatedly asked in pharma. This is an MCQ as well. Presence of tumor cells in peritumoral vascular or lymphatic spaces strongly associated with the presence of lymph node metastasis is a predictor of poor overall survival. If you can find tumor cells in peritumoral, around the tumor vascular blood vessels and lymphatic spaces, that is associated with the presence of lymph node metastasis. So and we already studied that if there is any lymph node metastasis, the prognosis is poor. Proliferative rate measured by mitotic counts, like mitotic figures, and immunohistochemical staining for Ki67. This is an MCQ. If the proliferation is high proliferation rates correlate with poorer prognosis, but better response to systemic chemotherapy. Gene expression profiling molecular subtypes. Modern classification divides breast cancer into luminal A, luminal B, HER2 enriched, basal-like, or triple negative. Assays like Oncotype DX or MammaPrint evaluates the expression of multiple genes to predict the risk of recurrence and benefit from chemotherapy.